Hello, everyone, and welcome to the Neuroplasticity Alliance's Therapy Innovation Summit 2022. I'm your host, Sherry Odom, and it's a real pleasure for me today to bring you a conversation with Dr. Deborah Zelinsky. Dr. Zelinsky is the founder of the Mind-Eye Institute located in Chicago, Illinois, and she's a true visionary in the area of neuro-optometric rehabilitation. Dr. Zelinsky has developed some unique methods to measure the eye's performance in conjunction with the brain's processing of that visual data. Individuals with a wide range of neurologic dysfunction can benefit from this program, and that includes brain injury, which you'll hear more about today, learning differences, vertigo, and much more. You can take an assessment located on her website to see if your situation would be a good fit. Dr. Zelinsky is also on a mission to leave the 2020 eye exam in the 20th century. It's a movement to recognize the shift in our visual usage of screens and technology rather than being focused on free space, which is the foundation of the 2020 eye exam as it was developed in 1862, which is still in use today. Dr. Zelinsky's use of eyeglasses to treat retinal processing has been applauded on a global basis. She's been recognized as a fellow and a founder of the Neuro-Optometric Rehabilitation Association, and her unique perspective has led to her receipt of awards from the Women in Optometry Association, as well as leadership positions from the Brain Mapping Association. Dr. Zelinsky is joining us from home today, where she's recovering from a severe back injury, and we are very thankful for her resilience in working through the pain. Dr. Zelinsky, thank you again for joining us today and being with us in spite of the situation. Welcome to the summit.
Nice to be here. Thank you, Sherry.
I know you are on a mission, Dr. Zelinsky, to help people with neurological dysfunction understand the difference between the classical eye exam, the 2020 eye exam that we all know, and the full scope of the visual processing that the brain can do. Would you take just a few minutes and start us off with an explanation of what that really means?
Sure. Would you like me to share my screen so I can show diagrams too?
Yeah, please go ahead.
All right. Here's an example of a classical eye examination. People put a letter chart on a wall, you sit down and you read the letters and identify them. That's drawn with a white beam of light here, and it's showing what you're paying attention to. That's assessing, according to Patrick Quaid's research in Canada, 6% of your view. It's your central eyesight, what your macula is seeing, but it's not prioritizing the other 94% of the surrounding view. That's drawn here in blue and green. The white part is measuring your central attention. The blue part is your subconscious attention, and the green part is your subconscious awareness. So there's a relationship between what you're aware of with your peripheral eyesight and what you're paying attention to with your central eyesight. And when you have a classical eye examination, the peripheral eyesight tends to be blocked off and you're focused straight on a central target. So the difference.
Yeah, I'm sorry, go ahead.
Right, that's it.
Okay, well, the follow-on question I have, so to me, when you're going to the optometrist and testing the 6%, you're missing the entire 94%. And does that get tested anywhere else by any other physician?
It does. Peripheral eyesight is tested by every physician to make sure it exists, because if it doesn't, that means you have some sort of problem. What we do at Mind-Eye Institute is emphasize the interaction which happens every day between the 94 and the 6%. And it's not just can you see, on the periphery and can you see in the center, it's do you interact with them. The general population is fine testing just the center. And the reason they do the center and emphasize it is there's a 1 million signals coming from that little spot filled with details. And there's only about 200,000 signals coming from the surrounding. So even though it's not as great of the signal input, they're more important signals. So these are the types of questions that pop out of the side peripheral eyesight. And then when you deal with the object and point where it is and what is it, that's when you're actually identifying the letter. So you have non-image forming connections in yourself. So these are things connected to the retina. There's signals on how your energy is, how safe you feel, what your interest or motivation is. Do you actually care about the target? The luminance in the room. There's sensors in the eye, in the retina, that link with all these different places. Some that link with where your hip position is. So if the light is coming from above, you're going to look up reflexively and your hips will shift. If light is coming from below, you'll have your hips shift forward. If light comes from the side, your hips shift also. So we have all of these things that are connected to the retina. That's part of the 200,000 signals. But then you get into the million signals for details on the object of where you're putting attention. And all of those together get into a final motor decision of what to do about it. So when we look at all of these pathways, you can look at it this way. There's 126 million sensors in each retina, and there's a filtering effect so that only 1.2 million neurons exit. So you have 126 million inputs, but only 1.2 million outputs. So during all that filtering, that's where the fun stuff happens. And when we use glasses, we can alter which of the 126 million sensors get information. Whether you use a prism to shove the information to one section or another, you can use a color to filter out some of the sections, changing luminance, a lot of different things. Those signals that go in the retina have two different places. Some are non-image forming and some are image forming. The image forming ones are eyesight, central and peripheral eyesight, and the non-image forming ones link with things like posture, jet lag, mood regulation. Now, I did this back in 1996. It's 26 years later now, and finally, there's so much research documenting the effects of retinal signal processing. Here's an example of 20/20 eyesight compared to the non-eyesight and peripheral eyesight signals. The non-eyesight signals link with the posture, metabolism, and mood. So this man is very alert, very tensed, and very agitated. And his peripheral eyesight gives him the speed, location, size, and shape of the oncoming threat. But to make a decision, he doesn't have to use central eyesight at all. Using central eyesight here would just have him be eaten because he doesn't have time. It's a slow pathway. So when driving, people don't use the 20/20 eyesight pathway much at all. That 6% we talked about when you're driving is used just to read a license plate or read a street sign, but not to drive. Driving uses all the peripheral eyesight, which is much faster. And you're judging speed and location of cars as opposed to any details on the car. There's a continuum of how you use your peripheral and central eyesight, and it goes from a penlight mode to a floodlight mode. The floodlight mode, if you're living in there all the time, people get labeled with attention deficit problems because the periphery is just blasting information and it's hard to pay attention. If you're in the opposite, in the penlight mode, then your central eyesight is paying attention, but you're not able to be aware of your surroundings. People get labeled autistic if they're too much in penlight mode. Now, everybody can shift from one to the other, but people with brain injuries and autonomic dysfunctions and genetic disorders, it's very hard to shift back and forth. They usually live a little bit skewed, more toward penlight, more toward floodlight. The average person will stay in the middle, and then when needed, scan with the floodlight or zoom attention with the penlight. And this is kind of, Sherry, an answer to your original question of what we do differently. conscious mind looking at a target and paying attention. That's a standard eye exam, which is fantastic for the bulk of the population. But for the people with brain injuries, neurological deficits, autonomic dysfunctions, genetic problems, learning problems, something where the brain isn't quite working the way it ought to, then we look at a lot of other stuff, the space and time judgments, the personality traits, whether you're an introvert or extrovert, to pay attention and be aware of your surroundings, where you are for your posture, how you feel, those types of things. And then the final conclusion of what you do about it. What optometrists can do is alter the perception of the space around them. And by altering the perception, you alter cognition. And you had said that Donnelly Marcus is being interviewed. She's the specialist in cognitive restructuring. I work with changing the input of the perception.
So when we talk about you're widening the visual processing scope and testing that. I know that you're also looking at auditory space. How are you syncing these two?
Well, we're measuring the perceived map of auditory space with my Z-Bell test. I patented that and have been using it for many years. We're measuring the visual space through partly the Z-Bell testing and partly standard optometric testing. And then we're figuring out where there's a skew, like if your auditory space map doesn't match the visual map. Let's say you have a visual midline shift from a brain injury, you might not have an auditory shift. And we're putting glasses on to make the two of them link together so that people are more comfortable. Basically, if your eyes and ears don't match each other, then your brain's going to be confused. The confusion is going to create stress chemicals. The stress chemicals is going to shrink your awareness. And it's a vicious cycle.
Okay, that explains so many of these neurological dysfunctions and how that works and how it all ties together. Can you walk us through what a patient would experience when they're coming to you for some type of dysfunction? And then I guess before you answer that though, maybe could you go through a description of all of the things that you have treated and you have experience with in your patient population?
Well, I've got 40 years of doing this, so I don't want to go through every single thing I've seen. But we see, I mean, years and years ago, I had an emphasis in low vision. So I directed clinics for macular degeneration, and we saw a lot of macular degeneration, a lot, even way back when in the 80s, I kept noticing that I had a lot of macular degeneration patients who had trouble with their thyroids. And I remember asking some physicians back in the 80s, you know, it seems weird that so many older people have thyroid medications and then all of a sudden get macular degeneration. And they said, no, old people just get macular degeneration. There, you know, and I said, it just seemed if you took a lot of older people, it doesn't seem like all of them would have thyroid changes. But it was years later that research started showing that there were connections between the thyroid levels and macular function. So probably going to be another 40 years before people figure out exactly what's happening.
Yeah.
But I've had background in low vision, lots of low vision, and then brain injuries. I used to do children who had been near drowning victims in South Florida way back in the 80s. I mean, that's close to 40 years ago. Recently, because of Clark Elliott's book, The Ghost in My Brain, we've had more and more brain injury patients be seen. My practice had been about 60% learning disabilities and it had changed and morphed into more brain injuries after The Ghost in My Brain came out. So we've seen brain injuries are never the same because the person who's injured is never the same. So we see a lot of brain injuries, a lot of learning problems, a lot of genetic mutations. As I said earlier, just autonomic dysfunctions, something where the brain just isn't working right.
Yeah. And how about people with neurodegenerative disease like Parkinson's and multiple sclerosis?
I see some of those patients, those are much, much harder to work with because it is a degenerative condition. We can't do anything to stop the degeneration. Sometimes you can placate some of the symptoms. Um, the auditory visual linkages have been shown to occur in neurodegenerative diseases. And there's newer studies, brand new, on schizophrenia, bipolar, also Alzheimer's, and multiple sclerosis, and Parkinson's with dementia, how the retina is thinning in different spots. So the retina is a piece of the brain. It's an extension of brain tissue. And what's happening is they're finding that if the retina is changing, it's doing that first before the brain changes. So there's newer studies showing how you can use the retina to pick out people who would have Alzheimer's. You can do a retinal scan in your 40s to show what might happen in your 80s. There's scans for, like I said, dementia, schizophrenia. So I believe that the retinal neuromodulation, that transfer of the 126 million signals down into 1 million, that holds a key that people aren't necessarily thinking about, that you alter the retinal neuromodulation to change the actual brain plasticity instead of just watching it disintegrate.
Oh, wow. That's so fascinating. And so as research continues to grow, it's likely we're going to see a big difference then in the role that treating your visual processing is going to play in the treatment of all kinds of diseases.
Yes, absolutely. I mean, that would be my vision for the brain mapping organization, that there would be more awareness of how retinal processing is affecting brain processing, and that changing the retinal signaling will be altering and modulating brain activity.
Dr. Zelinsky, let's dig into a little bit about how you apply all of this to treat patients. Can you walk us through what somebody would experience when they come into your office, and from the very first time they see you through to the end of their treatment from a follow-up standpoint?
Sure. They would schedule an appointment and be asked a lot of questions so that we had the history extensively done before they came. The history would include, what types of injury they had or what types of conditions, um, whether their thinking process, it would be more of mind and body. Is their mind more affected or is their body more affected? And how they do with the environmental changes. There are people who stay in their homes with darkened windows and live in a cave because they're so light sensitive. There's other people who are not able to function mentally. They can't make decisions and they get kind of paralyzed. So we check into all of that. Then they come for an appointment and we assess many, many, many visual skills. So people don't tend to realize how many visual skills you have. There's internal ones where you create mental images. There's external ones where you're looking around and processing. Then you have the shifting, the conversion of words into pictures when you're reading, or pictures into words. How do you use numbers? How do you scan? How do you choose, which chunk of space do you choose when you're given a room in front of you? What is your attention on? Those types of things. And we'll test a lot of visual perceptual skills, a lot of visual motor skills, a lot of visual processing. And from there, we'll also measure how we change lenses, how adaptable you are. So we're looking at attention and awareness on the outside. We're looking at attitude and adaptability internally. And depending on what we find, we might prescribe a pair of glasses to, like I said earlier, synchronize your auditory and visual perceived maps. We might prescribe glasses to just push you a little bit into having a new experience and having you readapt to the change. That's all at this point. And then depending on how you respond to what we're doing, there would be a follow-up visit. So we could say, you started at a certain place, we intervened. How'd you do? Did you stay the same? Did you get better? Did you get a lot better? And at the follow-up visit, measure what was hard for you before, and then go from there.
So a patient is going to receive, after the testing, a pair of glasses, yeah, typically. And will they have to come back for additional types of glasses or as they progress in advance?
Yes, they would, because what the glasses are doing is acting like a crutch. So you'd have, the first pair of glasses might be like a wheelchair, and the second one be like a walker, and the third one more like crutches, and the fourth one more like a cane. So you need help, but you don't need, all the help. Most of the time, what we're doing is using glasses to either activate the periphery if you're too much of a pen light person, or mute the periphery if you're too much of a floodlight person. And sometimes we have two pairs of glasses where you shift back and forth to create the adaptability.
I know that it's hard, and I'm not trying to pin you down on a time frame, right, for each patient, because I know it varies so much depending on the challenge that they're dealing with. But can you give us a range of how long it would take maybe for different types of challenges?
I mean, we'd be shocked if something were quicker than 3 months, and we'd also be shocked if it were longer than 2 years, 2.5 years. It depends on compliance. It depends on, again, your attitude. When you have a patient who comes in playing the victim and they're just miserable and they're already pre-convinced that absolutely nothing will help them, and they refuse to do any work to learn a new way to do things because they want to do it the old way that they've done for 75 years, then you can't help them. So, then it doesn't matter how long you have. So you have to have a patient like Clark Elliott who had the right attitude of, you tell me what to do and I'll do it. And the ability to say, I understand that my brain won't work the way it used to. Let me get a new brain pathway built through brain plasticity. And I'll just start with it being a little tiny dirt road in my brain, and we'll work it up to a superhighway. So the attitude of the patient is one of the key factors. I mean, we can't pull you along and make you see better. We can't make you process better. We can only guide you and create the environment coming in to be easy for you to then learn. It's amazing. So your time estimate is going to be based on how hard you work, and do you work within your abilities, or do you push yourself over the edge so you're too stressed out? I mean, that's another factor that we find.
Yeah, I think that gives, just based on my experience of what you're doing, that's a great answer for that. I think it gives people a good idea. You got to work hard to get it done. And that's the case with any neuroplastic protocol or treatment or technology. You got to put in the work yourself.
And it's really hard because some of these people, were Einstein-like and could do mental math manipulations, and then they get a brain injury and can't, remember 3 digits without double checking. And it's really frustrating. So you have to overcome all that emotional piece first, kind of grieve for your loss, and then go plowing away and making a new thing. It would be as if you were told you can't learn to speak English again. You have to learn a brand new language you've never had before. But once you do, you can become super fluent. And some people will say, I don't want to, and other people will just deal with it and say, I'll take 2 years and run with it, and then they're fine.
Yeah, I know you mentioned Clark Elliott just a few minutes ago, and he's also going to be one of our speakers in the summit. Are there any specifics around his treatment or any insights from that patient story that you wanted to share?
Well, I saw him in 2008, so that was almost 15 years ago. And so the research has shown a lot more since I saw him. So if he came today, his rehab would not have taken 2 years. It would have been more like 6 or 8 months. So what we would do now to him would be very different from what I did.
Well, and that leads me to a question about research. There's been so much done in the years that you've been doing this, and I know you're continuing to improve your program. What's some of the research out there now that's interesting to you, and maybe share after that a little bit of the research that you're working on yourself?
Well, the newest research is from about a year ago, where a brand new cell in the retina was discovered. It's so small, it could only be seen with a nanoscope because a microscope wasn't good enough, and nobody knows what it's for. It runs the length, like the entire thickness of the retina, and it's shaped like a bell, like a handbell, and nobody knows what it's for. It was just newly discovered, and they're like, "Oh, there's this new cell." There's also different pathways that have been found in concussion patients. That the way that people who've had concussions process glucose, which is a fuel for the brain, is different than people who haven't had a concussion. So those are the types of research that seem really fascinating to me. But retinal processing is a really hot topic because they just never stop learning about what the retina is connected to and how light affects it. My research specifically would be more about auditory visual interactions. I'd be looking more at my favorite thing to do is work with reading problems in children. But as people have had brain injuries and need to relearn how to read and scan, that's also fun. There's just so many aspects of optometry that are incredible. I see the future of optometry as the place people will go to get assessed before brain assessments. I see optometry as an adjunct to teams of practitioners because you need a team to rebuild a person.
Yeah, that brings me to a question about auditory processing and the syncing that you do with that. I mean, one of the other, I guess, professionals on this group is going to be Paul Madal from the Listening Center, and he was featured in Dr. Deutsch's book as well. And he does auditory processing. Are there times where you refer out to people like him and to help improve the auditory processing piece at the same time that you're trying to integrate those?
Absolutely. He's at the Listening Center near Toronto, and he's a phenomenal practitioner. It's a privilege to work with his patients. But yeah, we work with many different types of practitioners. So work with a lot of processing people, like you were saying, for sensory processing, and also body people for motor coordination or primitive reflex work.
Okay.
But again, I try to stay in my own lane, which is optometry. And what optometry is visual processing. And that's using eyeglasses to change the way the environment comes in. But we absolutely work with other practitioners who have their own specialties.
Yeah, and unfortunately, there's only one of you, and you're only in one location, which is in Chicago right now. But I know that you're working to develop a program to help train, I believe it's optometrists worldwide. Did you want to talk a little bit about that program and when it should be out?
Well, sure. We have 5 levels of processing. The first level would be knowing what glasses actually do to space when they magnify and minify and how they shift people's posture. Then the second level, so basically know your prescription and what it's doing. The second level would be about the auditory space and how to match the visual space and posture. And the third level is about visual processing internally, how people view concepts and details, how they sort things out in their mind, what they pay attention to, strategic type planning. The fourth level, chemistry level, where there's receptors in the retina at different levels. So when people are stressed, like I said earlier, they'll have stress chemicals produced, or in the dimmer light, there's more glutamate produced in the retina. In the brighter light, there's more dopamine produced in the retina. So there's a whole level of processing there. The blood flow in a person's body nourishes the retina. And if a person's taking different medications, then that blood is going to have stuff in it that will affect retinal processing. And we have to understand how the different medications affect retinal processing, because we're changing retinal processing from the outside in. But if the blood has other things in it from the inside out, you don't want two things to mix with each other. That's the fourth level. And then the fifth level would be stepping back and looking at patient care from the legal point of view, because I'll be doing a speech this December for brain injury attorneys, and they have to understand that just because a patient checks out 20/20 and no eye movement restriction and no eye health problems, that does not mean that they don't have other issues. So what I said in one of my chapters is that neuroscientists are constantly finding new things happening with retinal processing, but that those discoveries in neuroscience are not necessarily carried over into eye care professionals. And so what the Mind Eye Institute wants to do is connect neuroscience and optometry together. So our tagline is connecting optometry with neuroscience.
And the 4 program or the levels that you just described, these are the training programs that somebody would go through to become certified for your treatment protocol?
They would be a certified Mind Eye practitioner, and then their practice would join in with Mind Eye. So we would have one Mind Eye practice, but we'd have different locations, or we would train a practitioner and then position them in another location. As far as when that will happen, which is what you had asked, I don't know. It's that's in the future. We're working toward that, but first we have to solidify the Chicago practice.
Okay, great. So how would a practitioner who's interested in becoming certified get in touch with you? Should they just reach out directly to you?
Yeah, they should reach out to the office.
Okay. And how do they get in touch with them? What's your website?
The website is mindeye.com. So MINDEYE.com. And then if they want to email, it would be info@mindeye.com.
Okay. Dr. Zelinsky, thank you so much for joining us today. And I guess before we sign off, I'll give you an opportunity if there's one sort of party message you'd like to leave with our audience.
I guess the parting message I'd like to leave with your audience is to never give up. I mean, listen to what Clark Elliott went through. He had 8 years of problems. There's always brain plasticity that changes you as long as you allow it to change. So keep using logic and not listening to people tell you that, you reach the end of your rope or there's nothing more that can be done. Patients often ask the wrong questions, so they get the wrong answers. So if you change how your questions are phrased, sometimes you'll get different answers.
I like to leave it on a note of inspiration. Thank you,
Okay.
Dr. Zelinsky.